Hello to everybody. I'm Dr. Tullio Palmerini from Bologna, Italy, and I'm with Dr. Marie-Claude Maurice, who really doesn't need any presentation, from Paris, France. And we are here to moderate this exciting session, which is on late-breaking clinical trials. So we have three great presenters. Each one will have 8 minutes for abstract presentation, and we will have a 7 minutes discussion. With me, there are also panelists, Dr. Chen, Dr. Gupta, Dr. Iolasi, Dr. Lo, Dr. Santoso, who will help us in the discussion. So without any further ado, let's introduce the first speaker, who is Dr. Saito from Shonan Makura General Hospital, Japan. The title of his presentation is an evaluation of a sirolimus eluting bioadaptor as compared to zotarolimus elutistan in de novo coronary arteries, the BIOADATOR randomized control study. Please.
Thank you very much. My talk will be about bioadaptor RCT studies, which compare sirolimus eluting Dynamics bioadaptor system with zotarolimus eluting stent in de novo coronary arteries. For this presentation, I have no disclosure. Best-in-class DES do a good job, but still there is an unmet need. Adverse event rate occur in 2 to 3% every year, with no plateau. 5 and 10 years MACE reach 21 and 46%, as noted in the Resolute all-comers trial and ISA test for randomization trial. These MACE may be attributable to the permanent caging of the artery by stent, which results in loss of positive adaptive remodeling, loss pulsatility, loss of bath motion, and loss of vessel compliance. Dynamics bioadapter system has the best performance attributes of DES. It is characterized by 71 micron thin strut and good deliverability and good radial strength, which are best in class. Dynamics bioadapter has 6 months bioresorbable polymer and 3 months low-dose sirolimus coating. Dynamics bioadapter has unique uncaging elements, which restore vessel function and make it possible to adapt the vessel physiology. This unique characteristics is totally different from drug-eluting stent, which cages the vessel. Dynamics has a unique 3 uncaging elements. Dynamics has 3 uncaging elements in each circumferential ring, which locate in struts and safely disengage in 6 months, then leading to the restoration of normal vessel physiology, such as positive adaptive remodeling, pulsatility, compliance, and bath motion. This was published in Eurointervention. After drug-eluting stent implantation, the artery wall is caged so that it cannot show positive remodeling. Because of neo-intimal hyperplasia, the lumen diameter is getting smaller by 3% in 9 months. However, after Dynamics bioadapter implantation, both vessel and device grow up by 3 to 5%, and the vessel lumen diameter is compensated and does not change. This interesting data was presented at ACC 2021. The left panel is showing physiological dynamic change in systolic and diastolic diameters after Dynamics implantation. Stationary OCT image shows the pulsatile dilatation of Dynamics segment. In this case, coronary blood flow increased by 30% in diastole. The right panel shows the response to arterial dilator drug nitro injection. Immediately after Dynamics implantation, the vessel is still caged and the lumen area is not changed, even after nitro injection. However, in 9 to 12 months, it is uncaged and lumen is enlarged significantly by nitro injection. This slide shows the Dynamics restores vessel dynamic compliance. In the left panel, it is shown by using finite element method how much vessel compliance is improved in comparison to regular DES. In the right panel, you see that normal rotational movement and compliance are restored after Dynamics, but not after drug-eluting stent implantation. This slide shows vessel angulation can be restored after Dynamics implantation. Before Dynamics implantation, mean average angle was 137 degrees. Immediately after implantation of Dynamics, the vessel was straightened to 157 degrees. However, at the follow-up, the original bending is almost recovered. The flexibility by uncaging may contribute to the reduction of MACE in angled vessels. As a Japanese PI, I did an international one-to-one randomized controlled trial between Dynamics BIOADATOR system and Onyx DES. 222 patients were from Japan, and the other 222 patients were from Germany, Belgium, and New Zealand. Primary endpoint of this study is TLF at 12 months. We include OCT and IVAS sub-studies. Case enrollment was already completed, and we are waiting for long-term results. This is showing the study flow chart, showing the study design and clinical and imaging time points. We have, IVAS QCA study group for N equal 80. And for N equal 20, we have IVAS OCT QCA study. Elixir company has committed to a robust clinical study program to demonstrate the importance of uncaging the coronary artery. We have two RCT comparing between Dynamics BIOADATOR versus Onyx. The first one is our trial, and the second one is larger scale real-world trial, Infinity Sweden Heart RCT in Sweden. By improving shortcomings of previous technologies, interventional cardiology has evolved. The Dynamics BIOADATOR are major innovation beyond drug-eluting stent technology is designed to address the shortcomings of drug-eluting stents and leave no cage behind. It is a potential to improve clinical outcomes. Dynamics BIOADATOR has demonstrated the ability to adapt to vessel physiology. First, restore positive adaptive remodeling. Second, restore the vessel functions. And third, restore the vessel geometric dynamics. So, acute performance similar to best-in-class drug-eluting stents. And RCT will show the safety and efficacy of this system. And the study will demonstrate the BIOADATOR ability to restore vessel function. Thank you very much.
Thank you, Dr. Saito. Very nice presentation. Now the abstract is open for discussion. Any question for from the panelists, or Dr. Maurizio, do you have any question?
No, thank you, Prof. Saito. It's a very convincing technology, and of course we will wait for the long term to see if the concept of restoration of pulsatility and vasomotion is really solving the long-term adverse effect of drug-eluting stent. But it's a very smart and brilliant technology.
So are there any questions from the panelists? Or if not, probably okay, yeah. Dr. Santoso, please go ahead.
I have a question. I'm interested in this technology. I have a personal experience of only 3 patients, but the concept is very interesting. Then I think I completely agree with Dr. Saito that we foresee that the ultimate result long-term would be a reduction of restenosis and probably also other important problem related to stenting. For example, stent fractures may also be reduced.
Yes, I totally agree with your idea. And the main concept is like BBS. BBS unfortunately disappeared from the market, but this bioadapter may replace the position of BBS.
And I also,
Dr. Loh, please.
Thank you. I'm just wondering if the polymer dissolve in 6 months, within 6 months, the links, the adapter links will be gone. Will there be a reduction in the radial force of the stent itself?
Yes, that is a good question. Yes, I had the same question. And so I discussed with the developers of this system, and the answer was by 6 months, we don't need any, radial force for the stent because the vessel itself recovers to the normal physiological function. So actually, the radial force is decreased maybe about 50% after disengaging, but that kind of small radial force is not necessary.
I see. And immediately, if you've implanted this stent in a calcified vessel, perhaps, and you have to post-dilate, is there a small risk that this adapter rings may fracture if you high pressure the dilatation using an NC balloon up to 25, 26 atmosphere?
Yes, there is some risk of that kind of fracture, but actually the stent is caged because of the, to the link, connected link. There is, we don't need any kind of glue. That is just, we have just only the polymer coating. That kind of coating is keeping the two stent strut connections. So maybe if there is a severe calcification and also we did some kind of high pressure dilatation, there may be some risk of the disengagement. But I think for that kind of regions, because we need some kind of calcium developing, like rotablator or something, shockwave or something.
Yes, probably also the shockwave technology may combine well with this device in a complex calcified lesion. But I have also another question. So this technology, in your opinion, aims for superiority or non-inferiority as compared to best-in-class drug-eluting stents? And in this case, how many patients would you really need to show superiority if you think that there will be superiority for this device?
You are talking about a statistical calculation?
Sorry?
You are talking about the statistical calculation?
Yes, I mean, I would imagine that for showing superiority, you would need a very large trial.
Actually, this study was constructed by using non-inferiority based. Because if we are going to the superiority, we need a lot of more patients, of course. That is not practical.
Okay,
I
think
to find out the
we can move
long-term.
to the next speaker. Dr. Maurice, would you like to present him?
No, I think you can continue. The next speaker is Dr. Seokun Yang.
Okay, so next speaker is Dr. Yang from Seoul National University Hospital, Republic of Korea. The title of his presentation is Prognostic Relevance of High-Risk Plaque Features in Guiding Treatment Strategy. Please, Dr. Yang.
Hello, ladies and gentlemen. I'm Seokun Yang from the National University Hospital. It is my great honor to present this topic in the prestigious stage. Today, I'd like to talk about prognostic relevance of high-risk plaque features in guiding treatment strategy. I am nothing to disclose. The presence of myocardial ischemia has been used as one of indicators for coronary revascularization. However, clinical outcomes may not be fully optimized by decision-making solely based on myocardial ischemia. In the ischemia trial that enrolled stable patients with moderate to severe ischemia, the initial PCI strategy did not improve the patient prognosis compared with the medical treatment alone. Beyond myocardial ischemia, quantitative and qualitative plaque features by various coronary imaging are also predictors of coronary events. IBUS-derived high plaque burden or small MLA, and OCT-derived various vulnerable plaque morphology, and coronary CT-derived adverse plaque characteristics are all associated with an increased risk of major cardiovascular events. Moreover, even in non-ischemic lesions, recent studies showed the presence of high-risk plaque features portended a higher risk of coronary events. But still, which component between quantity and quality is the main driver of clinical events, and how high-risk plaque in non-ischemic lesions can be treated are not fully investigated. In this regard, we performed this study to identify the individual and combined prognostic implications of quantitative and qualitative plaque metrics in non-ischemic lesions, and also to investigate their prognostic interactions with treatment strategies. The study population was from the International Multicenter TCTAP registry, a total of 697 vessels with suspected coronary artery disease that underwent FFR-guided treatment strategy and coronary CT angiography before FFR measurement were included. In the medical treatment group, deferred bed lesions with high FFR were included, and in the PCI group, revascularized lesions with high post-PCI FFR were included. All data were analyzed by independent core laboratories, and the primary outcome was vessel-oriented composite outcomes, VOCO, a composite of cardiac death, target vessel MI, and target vessel revascularization at 5 years. By plaque assessment of coronary CT angiography, we defined high-risk plaque as the best plaque metrics in prediction of primary outcomes. So, quantitative high-risk plaque was high plaque burden and small MLA, and qualitative high-risk plaque was the presence of low attenuation plaque or passive remodeling in coronary CT angiography. This table shows the baseline characteristics. Mean age was 66 years, and 72% of patients were male, and 81% of patients presented stable ischemic heart disease, and at the index procedure in which FFR was measured, 517 vessels received medical treatment, and the remaining 180 vessels underwent PCI. And the mean FFR value was 0.85. In the medical treatment group with high FFR, quantitative high-risk plaque and qualitative high-risk plaque were all associated with the increased risk of 5-year VOCO. However, when these high-risk plaques were considered simultaneously, as compared with both negative lesions, only both positive lesions had worse outcomes, but either positive lesions did not show an increased risk of primary outcomes. When we compare the outcome trend in medical treatment and PCI groups according to none, either, and both of quantitative and qualitative high-risk plaque, the event rate of vocal serially increased in the medical treatment group, but it was not different in the PCI group. For details, we compared the primary outcomes between medical treatment and PCI groups in each lesion subset by high-risk plaque status. In lesions with none or either of quantitative and qualitative high-risk plaque, there was no outcome difference between medical treatment and PCI groups, but in lesions with both of quantitative and qualitative high-risk plaque, the PCI group had 70% decreased risk of primary outcomes than the medical treatment group. Then, we considered the influence of physiological lesion severity on this association. In lesions with FFR of 0.81 to 0.9, there was a significant interaction between treatment types and the presence of both quantitative and qualitative high-risk plaque. But this interaction was attenuated in lesions with FFR over 0.9, and there was no outcome difference between medical treatment and PCI groups, regardless of high-risk plaque status. Finally, based on these findings, we proposed the risk assessment flow of non-ischemic lesions. When we encountered high FFR lesions, those with FFR over 0.9 can be safely deferred without any additional diagnostic testing. For lesions with FFR over 0.81 to 0.9, plaque quantity assessment may be needed, and low risk can be expected in lesions without quantitative high-risk plaque. But if quantitative high-risk plaque is present, additional plaque quality assessment may be warranted, and lesions without qualitative high-risk plaque can also be safely deferred, but lesions with both quantitative and qualitative high-risk plaque, which accounts for about 10% of total region in our study, should be regarded as high-risk lesions that require meticulous medical treatment or even coronary revascularization. Ladies and gentlemen, let me summarize this presentation. In non-ischemic lesions, which is FFR over 0.8, quantitative high-risk plaque and qualitative high-risk plaque had a synergistic prognostic impact on the clinical outcomes. And in lesions with both quantitative and qualitative high-risk plaque, the PCI group showed a better prognosis than the medical treatment group. And this association was only observed in those with FFR over 0.81 to 0.9. Several points can be discussed to interpret the result. The incremental prognostic value of plaque quantity and quality can be supported by Prospect 2 study that observed the highest event rate in lesions with both high plaque burden and high maximum lipid core burden index, and also better outcomes of quantitative and qualitative high-risk plaque in the PCI groups aligns with the pilot RCT study result Prospect observed that reported lower clinical events of BVS-treated lesions than medically treated ones among non-ischemic high plaque burden lesions. And differential prognostic interaction between high-risk plaque and treatment types according to FFR values may be due to very low clinical events in lesions with FFR over 0.9. These are the several limitations of the study. This was a post-hoc analysis of a pooled registry, so the result was confined to a hypothesis generation, and hard outcomes could not be analyzed, and invasive imaging studies were not interrogated. In conclusion, in non-ischemic lesions, quantitative and qualitative plaque features and physiological lesion severity can be helpful for risk stratification and selection of appropriate treatment strategy. Thank you for your attention.
Thank you, Dr. Yang. This was really a great presentation, which is now open for discussion. Any question?
So your your recommendation is that is to say, okay, in fact, FFR alone is not enough. Huh? It's the opposite of what we used to think. So that's in those intermediate FFR 080 or 90. Imaging is really needed. I don't remember how much you said it, but I didn't note it. How many patients between 080 and 090, which percentage were identified as patients that benefit from treatment?
Thank you for your comment. Actually, about 10% of total non-ischemic lesions showed both quantitative and qualitative high-risk plaques.
No, very good. It's good not to miss those patients. Huh?
Dr. Santoso, please.
Yes, first of all, congratulations for this very important clinical study. As interventional cardiologists, I think we are aware that sooner or later, some of our important works in the cath lab will move to the non-invasive territory, like the measurement of flow, CCTA, FFR, and evaluation of plaque burden, as demonstrated very nicely in your study. I have one question related to diabetic patients. We know that in diabetic patients, high-risk plaque is often observed despite very effective lipid treatment. How about your impression and during this study, whether your diabetic patient exhibits also a similar phenomenon?
Thank you for your comment. And actually, we didn't, in our registry, about 30% of patients had diabetes, and also diabetes showed more than 3 times higher risk of future events. And also, they had more high-risk features and low FFR, but we did not observe the prognostic interaction between the presence of diabetes and high-risk plaque and physiological severity. So when you compare the relative importance among those variables, the diabetes is the most strongest factor, and followed by FFR or other high-risk plaque features. So that means that the diabetes, the patient characteristics such as diabetes or CKD is the most important factor to determine the treatment strategy, but maybe it may not affect the treatment decision measured by high-risk plaque or FFR values. Thank you for your comment.
Dr. Gupta, please.
Yes, I wanted to congratulate Dr. Yang on this excellent work. It's very fascinating. You know, we've had this tension in interventional cardiology between anatomy and physiology, and in a way we're swinging back and forth and maybe getting the best of both worlds. With coronary CTA, we're learning so much about what's in the vessel wall, not just the lumen. Perhaps one comment is, can we improve the efficiency? Meaning, can we identify more patients rather than just end up with 10% at the end of the algorithm? So what if you divide like the FFR into 81 to 85? Because we've all had cases where the FFR comes at 0.82, and we're not, fully convinced, but by the book, we're supposed to, stop and just say this is a non-ischemic lesion. Would your algorithm be enriched if you made the zone of interest like 0.81 to 0.85?
Yeah, thank you for your comment. And actually, we divided by several cutoff value FFR, as you mentioned, and including the gray zone of FFR. But this court has a similar number of events, so that with the cutoff value of 0.85, there was no significant outcome discrimination for this algorithm. So it can be validated, and the optimal cutoff value for algorithm of FFR can be fixed in the future prospective studies, I think. Thank you for your comment.
Can I make one comment?
Please, Dr. Loh.
Yeah, thanks, Dr. Yang, for the very nice, impressive research piece of a good piece of work here. I'm just interested in the medical therapy here. Say I don't have access to CT angiograms and all these invasive things, and I don't have a data of FFR. Now, you have a 58% patients with hyperlipidemia. Yeah. Now, your hyperlipidemia definition is based on the total cholesterol or the LDL cholesterol. And then if you treat what level did you push it down to?
Thank you for your comment. The definition of hyperlipidemia is based on the total cholesterol and LDL cholesterol. Also, the use of the statin or other lipid-lowering agent. So it was at the physician's discretion. So following this definition, as you mentioned, that it may overestimate the prevalence of hyperlipidemia, but we are included a broad definition of hyperlipidemia for this study. And actually the patient who received statin in this cohort was about 80%. Yes.
So really exciting discussion, but we have no more time, so we have to go further and present next speaker, who is Dr. Kang from Seoul National University Hospital, Republic of Korea. The title of his presentation is 2-year outcome after PCI in high bleeding risk Asian patients, the Onyx 1 clear study. Please, Dr. Kang.
First, it's an honor to speak at the TCTAP 2022 LBCT session, and today my topic will be the 2-year outcomes after PCI in high bleeding risk Asian patients, and this was a sub-study of the Onyx 1 clear study. I have nothing to disclose. First, as an introduction, I would like to say that along with the improvement of PCI techniques and devices, more vulnerable patients are receiving PCI, and the high bleeding risk patients are a representative, very high-risk populations who are gaining attention and who have not been evaluated in previous RCTs that we have performed. The Onyx 1 RCT was the first trial to compare DES versus DCS in these high bleeding patients. And due to this study, we no longer use DCSs in those who have a need of any kind of shorter DAPT duration. Regarding the high-risk patients, Asians are known to have a unique ischemic and bleeding risk profile compared to those with Westerns. So it may be important to evaluate whether there may be a difference in the safety and efficacy of short DAPT between ethnicity, and this is an important issue that should be evaluated. So the study purpose of our trial was to evaluate the efficacy and safety of short-term DAPT between Asians and non-Asians with high bleeding risk. For definition, the efficacy and safety endpoint were defined as a composite of cardiac death MI for efficacy endpoints and a BARC 3 to 5 endpoints, bleeding and events for the safety events. We all see that these are very hard endpoints that are rarely collected in small size studies. And we use the Onyx 1 clear study for analysis. To give a short overview of the Onyx 1 clear study, this was a prospective multicenter single-arm study, which included those who received the Resolute Onyx stent from the Onyx 1 RCT, which included about 1,000 patients, and also a registry that included 750 patients from the Onyx 1 US and Japan study, and these were all high bleeding patients who underwent PCI. As I said, for efficacy endpoint, we analyzed the cardiac death MI. For safety endpoint, we analyzed the BARC 3 to 5 bleedings, and this was a 1-month clear population, which was patients who received 1 month DAPT and who were event-free, and those were precluded for a 1-month DAPT cessation. Also, as I will explain in the following slide, we performed a propensity score matching analysis due to the difference in the Asian and non-Asian population. As a graphical overview, this was the study that we performed. Patients from the Onyx 1 RCT and patients from the Onyx 1 single arm study were included in the Onyx 1 clear study. Those who did not have events during the first month after PCI were divided into Asian patients, 273 patients, and non-Asian patients, about 1,200 patients. And we performed a propensity matching by a 1-to-1 analysis. These are the baseline clinical characteristics between Asian and non-Asian cohort in the total population. And we could see that non-Asian patients were older, had a higher BMI, had more comorbidities such as hypertension, hyperlipidemia, previous PCI, etc. And also, interestingly, the oral anticoagulant usage and the potent P2Y12 inhibitor usage was significantly higher in the non-Asian cohort. Regarding to these kinds of clinical baseline characteristics, we can see that the HBR criteria was 1.5 per patient in Asians, 1.6 per patient in non-Asians with marginal significance, but we could see that there was large difference in the each factors of HBR. Regarding the baseline lesion and procedural characteristics, we could see that more patients were LAD lesion in Asians, more patients had severe calcification, more CTOs, more B2C lesions with a larger diameter stenosis, larger lesion length, etc. So these data can all be classified to say that in the unmatched population, non-Asian patients had more clinical complexity, while Asian patients had more lesion or procedural complexity. I think that these kinds of baseline clinical characteristics could have somehow influenced the outcome that I will show you in the following slides. So in the one-to-one matched patient analysis, we could see that the absolute standardized difference was around 5% for all features, which means that there were a minimal difference between the factors in the cohorts of the Asian and the non-Asian cohorts. And this analysis cohort, which included up to 520 patients, were the analysis cohort that we studied the outcomes. So based on the matched cohort, we could see that there was a slight difference in the each factors, which included HBR. However, statistically significant difference was only found in the age, and other factors were similar, especially for the oral anticoagulant uses, which you could see that this factor was very similar in the Asians and non-Asians, which was very different before the matching process. So in the outcomes from 1 month to 2 years, we could see that the ischemic outcome, the cardiac death MI outcome, was very similar between the Asian and non-Asian cohort. However, in regards of bleeding endpoints, Spark 3 to 5 bleeding endpoints, we could see that the Asian cohort was about 1/3 of the non-Asian cohort, and which this difference was statistically significant, showing that Asians had a significantly lower event rate of bleeding endpoints. Regarding other endpoints, we could see that there was no difference in other kind of clinical endpoints, including target lesion failure, target vessel failure, and also the BARC 2 to 5 bleeding, BARC 3 to 5 bleeding were significantly lower in the Asian cohorts, saying that the 1 month DAPT strategy and then single DAPT strategy in high bleeding risk patients may be relatively more safer in Asian patients compared to the non-Asian cohort. So this is a summary of the results. There was a significant difference in the baseline characteristics in high bleeding patients between Asian and non-Asian countries. And we addressed this by the propensity score matching, leading to a small standardized difference in the confounding variates. In Asian patients receiving the Onyx stent during PCI and treated with 1 month DAPT without events, during the following 2 years, they had similar ischemic events, but fewer bleeding events compared to non-Asian patients. I should like to point out 2 important points for interpretation of this data. This was a cohort of a 1 month event-free population, which means that the most vulnerable phase after PCI, the first month after PCI, was excluded. So that should be an important fact that we should consider in interpreting this data. And also, although that we performed propensity score matching for any kind of matching, we still observed difference in the Asian and non-Asian population. So the higher clinical complexity in non-Asian patients, the higher lesion complexity in Asian patients should be considered in interpreting the data. So this is the conclusion and the last slide of my speech. In the current analysis, we evaluated the ethnic difference of HBR patients who received the Onyx stent and who were treated 1 month DAPT without events. Asian patients were similar with ischemic events, but fewer in bleeding events, implying that a short-term DAPT may be safer in Asian HBR patients once stabilized during the first month after PCI. Thank you for your kind attention.
Thank you, Dr. Kang, for this very nice presentation. I think we have time just for a couple of questions. Any question from the panelists?
Yes. Can I ask? Congratulations, very interesting data. Do you know? I have two questions. First, do you know what was the single antiplatelet treatment? Was it aspirin mostly or another antiplatelet? And the second question, by curiosity, did you look at the first months, the worst one, as you say, in terms of bleeding? Did the Asian patient bled less also during that first month or not?
Yes, thank you for this very important comment. Regarding the antiplatelet usage, the percentage was slightly different between the Asian and non-Asian patients. Asians had a slightly higher population whom used clopidogrel. And in the non-Asian patients, there were some patients who used aspirin and some patients who used Postin P2Y12 inhibitor single, probably due to the recent trials that we have seen. And so this might have brought a difference with the outcome, but this is a further issue that we should evaluate because the antiplatelet is a dynamic issue. It changes every year, every month for the patients. Regarding the second question was it the first events during the first month? Is that correct? Yeah. Yes. Actually, this also is a point that we should add to the analysis because the first month, it was some patients were on triple, some patients were on dual. So it's a very vulnerable period, not only to the patient, but to the medication, how they use the medications. So we do have data of the first month, but it's very complicated to interpret how the ethnicity gives any influence to the first month event rate.
Thank you.
I'm also beginning
we are
to
just on
change
time,
my...
so time for the last question. Please, Dr. Lowe.
Oh, I'm just making a comment. I'm beginning to change my practice from clopidogrel. Actually, I'm using more and more ticagrelor, which to me is a better antiplatelet drug, you see. And I think this story about 1 month, 2 months, I think in the future may not be such an important issue anymore. I think the bleeding is because of DAPT due to aspirin, perhaps, you know. I think the usage of ticagrelor in the future may overcome some of these problems.
Yes, this is also a very important question. Everybody knows that the issue of DAPT, SAPT is not just a question of using 2 or 1. There's a how to use, what dose to use, when to switch. There's a very complicated question. So I do agree that not only for ticagrelor, for prasugrel maybe, or other antiplatelet agents that may come out, it's a very important issue that we should solve.
Thank you.
So I think we run out of time. So this was really an exciting session. So thank you to all the speakers, to the panelists, to Dr. Maurice, and thanks again. Bye.
Thank you.
Bye.
Thank you.
Thank you.
Bye.